disconnected for some reason. All right, so let's get to the good stuff. So here's our disclaimer statement, and this is just saying that this is intended to be a general overview, and it is current at the time of this presentation, but this information, especially with COVID, changes daily. So if you're watching this recording after the live recording, you may want to just verify that it's still up to date at the time that you watch it. So for our agenda today, we're going to review recently released ICD-10 CM codes that have to do with COVID. We're going to go over recent updates of the Emergency Use Authorization, or EUAs, for the monoclonal antibody treatments and vaccines and boosters, including the ICD-10 PCS codes and the CPT-HCPCS codes that have come out since our last COVID update, which was November 2nd. And then we're going to go over some FAQs and special case reviews. The goal of this presentation is really just to cover all of the important changes that have happened since our last update on November 2nd. So first of all, just a general COVID update. The public health emergency was last authorized on January 14th. So April 16th is the deadline for them to file a new public health emergency. There was a letter that was written to the state governors stating that they will give a 60-day notice if the PHE won't be renewed. So just keep an eye out for that. We are expecting for it to be renewed to allow for the flexibilities and waivers to continue, since we are still dealing with Omicron. All right, we're going to jump into new diagnosis codes. So we have two new diagnosis codes here. The first is Z28.310, and this is unvaccinated for COVID-19. And we have Z28.311, which is partially vaccinated for COVID-19. I have some updated guidelines here that just explain that the Z18.310 should only be used if the patient has not had any vaccinations for COVID-19. And then the Z28.311 would be used if they just haven't had the full regimen. So like if the dosage, if they should have had 3 dosages and they've only had the first, that's when you would use that partially vaccinated for COVID-19. Also a note on this, that if the patient is not eligible for the vaccine, these codes should not be used. So for example, if the patient is underage and would not be eligible for a vaccine to begin with, then you should not assign these codes. Okay, so if the patient is eligible for the vaccine, but they've never received a vaccine, or they only have the partial vaccine, you would first code the Z28.31 code, and then you would use an additional code to identify why. So this could be due to a contraindication. It could be a patient's decision because of religious reasons, and you have several codes that give more description on why the patient is not vaccinated or is only partially vaccinated. So another code that was effective April 1st references all immunizations, not just COVID. So this is Z28.39, and it's other under immunization status. So this is just kind of like a blanket code saying that the patient is either has a history of being under immunized, is behind on immunizations due to an alternate schedule. So sometimes patients choose to go a little bit slower on their immunizations than what's recommended for various reasons. So just a reminder, this is for any immunizations. It is not only for COVID immunizations. All 3 of the new diagnosis codes are non-comorbid conditions, and they will not impact the MSDRG if they're assigned on an inpatient encounter. All right, so now we're going to talk about vaccine, booster, antiviral, and monoclonal antibody updates. And this is going to include all of the new CPT-HCPCS and PCS codes that have come out since our last update in November. So just a warning, this is lots of information. I put it in a timeline order to try to keep it as simple and organized as possible. But like I said earlier, there's constant changes to this information. So if you really want to keep up with this, I would recommend checking the FDA website, checking the CMS website. Those are really the two places where I like to check to stay on top of what's going on. All right, here we go. So back in November 19th, the FDA amended the emergency use authorization for Moderna and Pfizer to authorize a booster dose for patients 18 years and older. This would follow the completion of the primary vaccination series. They said it would be given at least 6 months after the Moderna or Pfizer vaccine and at least 2 months after the Janssen vaccine. So the codes for these booster vaccines are not new. They were actually included in detail in our last presentation on November 2nd. So if you want more detail on these codes, I would recommend going and check out that presentation. It was called, "Oh no, not another COVID update." And but those codes are the 0004A, which is the Pfizer booster, 0034A, which is the Janssen booster, 0064A, which is the Moderna booster, and then 0054A, which is the Pfizer trisucrose booster. All right, so moving on to monoclonal antibodies. Effective December 3rd, 2021, revised the EUA of bamlanivimab and etesevimab. It was previously authorized for pediatric patients that were over 12 years old and weighing at least 80 pounds, but this revision authorized younger pediatric patients to be given this antibody, even including newborns. So the patient has to be COVID positive and they have to be at high risk for developing severe COVID. This revision also authorized these medications to be administered together for post-exposure prophylaxis for prevention of COVID-19 in all pediatric patients who were at high risk for COVID. So effective December 8th, 2021, Medicare set the payment rate for administering COVID-19 monoclonal antibody products through intramuscular injection. And this is for pre-exposure prophylaxis. And that payment rate was set at $150.50. And just to note, reimbursement will be wage adjusted for your geographical location. Also on December 8th, CMS set the payment rate for administering the monoclonal antibodies intramuscularly for pre-exposure prophylaxis in the patient's home or residence. And this payment rate was set at $250.50. All right, so December 8th was a very busy date. The FDA granted AstraZeneca's Evishield, which is tixagevimab and silgavimab. And this is for the pre-exposure prophylaxis of COVID in adults and pediatric individuals. And when they say pediatric individuals, they mean children that are over 12 years of age and at least 88 pounds, and that are not currently infected with COVID and have not experienced any recent exposure to COVID. So this is for patients who have moderate to severe immune compromise, either due to a medical condition or some type of medication they're on that compromises their immune system. And they are expected not to have an adequate immune response to a vaccination. So this is given instead. This is also recommended for patients who have had a history of a severe adverse reaction to a vaccination. So they would be given the monoclonal antibodies instead. We have a new PCS code for this, XWO23X7. And it's 2 medications, and they are administered as 2 separate consecutive intramuscular injections, but only a single code is reported for the full dose. And here are the new HCPCS codes for the Evishield. The drug code is Q0220, and you'll see that I have the milligrams, the 300 milligrams highlighted. I'm just pointing this out because later down the line, the dosing did change whenever we had a new variant. They did change the dosing to adjust it for the new variant. So we'll go over that later. So this is free of charge, and it if there's sometimes instances where a claim scrubber requires the drug to be reported with the administration. You can use a 1 cent charge if that's the case. The administration code is the MO220, and this includes the injection and the post-administration monitoring in a healthcare facility. And this is $150.50 for reimbursement. And then the next administration code is M0221, and this is for the injection in the home or residence. And it the reimbursement is $250.50. All right, effective December 9th, 2021, the FDA amended the EUA for the Pfizer vaccine and authorized a single booster for individuals 16 and 17 years old 6 months after completion of the primary vaccine. So back in November, the FDA had authorized the single booster dose to administration for individuals 18 and older, but here they're just expanding it to 16 and 17-year-olds. All right, antivirals. So effective December 22nd of 2021, the FDA authorized an EUA for 2 new antiviral medications. The first is Pfizer's Paxlovid, and this is a tablet, and it's for the treatment of mild to moderate COVID-19 in adults and pediatric patients, which are those 12 years and older, weighing at least 88 pounds. The patient must have a positive result. The patient must be at high risk with likely progression to a severe COVID infection that could include hospitalization or death. The drug should be initiated within 5 days of symptom onset. It is not authorized for pre or post exposure prevention, and it should not be started with patients who are already in the hospital with severe COVID, because the benefit of treatment has not been observed in people when treatment started after hospitalization due to COVID. So the drug should not be given if the patient is already severely ill in the hospital. And this new antiviral qualifies for the new COVID-19 treatments add-on payment, that 20% additional payment for inpatients. This drug does qualify for that. Also on December 23rd, well, this is on December 23rd, the next antiviral that was authorized was Mercs Malnuvar, and this is also for the treatment of mild to moderate COVID-19 in adults over 18 years of age. So this one can only be given if the patient is at least 18 years old. And the reason for that is because they found that the drug may affect bone and cartilage growth in younger children. The patient must have a positive result. They at high risk for progression to severe COVID. The drug should also be initiated within 5 days of symptom onset, and it's not authorized for pre or post exposure prevention. This one also should not be started on patients who are in the hospital with severe COVID already, and it also qualifies for the new COVID-19 treatment add-on payment. Okay, so now we're going to talk about some vaccines and booster updates. And this is just to clear up some confusion about the effective dates on the Pfizer tri-sucrose vaccines. Here's a little background information. On September 3rd, 2021, the AMA released new CPT codes for the tri-sucrose formulation of the Pfizer vaccine, which was the 91305 code. And the administration codes, you can see I have listed here for the administration codes. On October 29th, 2021, the FDA authorized the vaccine. However, CMS is identifying the effective date as January 3rd because they said that the product was not available to Medicare providers and suppliers until January 3rd. So if you see the effective date of January 3rd in our VitalWare system, that is why. It's because CMS is identifying that effective date as January 3rd. All right, so effective January 3rd, the FDA amended the EUA for the Pfizer vaccine to expand the booster dose to ages 12 to 15 years of age, and to shorten the time between the completion of the primary vaccination series and the booster dose. So it used to be 6 months, and they're shortening it to 5 months here. So between your third vaccine, your second or third vaccine, and your booster dose, it goes from 6 months to 5 months. This amendment also allowed for a third primary series dose for certain immunocompromised children 5 to 11 years of age. And we have new codes for that third Pfizer dose that were effective January 3rd. The new CPT code is 0073A, and that's for the third dose of the Pfizer vaccine. And the new PCS code is XW023V7. This new third dose requires reconstitution using a diluent to reach the appropriate dosage. It should be administered 28 days after the patient's second dose, and it is specifically intended for immunocompromised children 5 to 11 years old. And these are patients who have either undergone a solid organ transplant, or they are diagnosed with conditions that have an equivalent level of immunocompromise. And I've included a link here all the way at the bottom of the slide that you can see what they consider an equivalent level of immunocompromise. And counseling as well, counseling is included as part of the administration, so it should not be reported separately. All right, effective January 7th, 2022. So we knew this was coming since Pfizer's time between the last dose and booster was shortened. Here, the FDA amended the EUA for the Moderna vaccines to shorten the time between the completion of the primary series and the booster from 6 months to 5 months. All right, January 21st, the FDA approved the use of Veklury, which is remdesivir, for use in the outpatient setting. And they also revised the EUA for treatment of pediatric patients. And they have defined pediatric patients here as patients weighing 3.5 kilograms, which is 7.7 pounds, to less than 40 kilograms, which is 88 pounds, or patients less than 12 years of age weighing at least 3.5 kilograms, which is 7.7 pounds. The patient must have a positive result of COVID. They should not be hospitalized when given this, and they should have mild to moderate COVID, but they should be at high risk for progression to severe COVID. And this medication is received through an intravenous infusion for a total of 3 days on an outpatient basis. We have a new code for this. It's J0248, and this code represents 1 milligram, and you should report units to reflect the dosage for that you administer to the patient. Just a note on this, the federal government isn't purchasing this. Medicare Part B will provide payment for the drug and its administration under the applicable Part B payment policy when you provide it in an outpatient setting. So in most cases, the patient's yearly Part B deductible and 20% coinsurance will apply. All right, effective January 24th, 2022, the FDA revised EUAs for 2 monoclonal antibody treatments, bamlanivimab and etesevimab. They are administered together, and also Regencov, which is casirivimab and imdevimab. And they revised the EUA to limit their use when the patient is infected with a variant that is not susceptible to these antibodies, because data was showing at the time that, you know, Omicron was on the rise, and these antibodies were very unlikely to be active against Omicron. So that's why they made this adjustment. All right, effective January 31st, 2022, the FDA fully approved Moderna's COVID-19 vaccine, woohoo, and marketed it as Spikevax. That's the new name, and it is for patients 18 years and older. This product has been available under EUA since December 18th, 2020. It's the same formulation, it just has a fancy new name. It what they mean when they say it meets the FDA's full approval is just that it meets the rigorous standards for safety, effectiveness, and manufacturing quality that's required for the approval. And this is administered as a primary series of 2 doses 1 month apart. Okay, so effective February 1st, 2022, they released new codes for our pediatric Pfizer vaccine, the tri-sucrose formulation, and this was released for ages 6 months to 4 years. Just to note, this vaccine has not been EUA approved yet, so it cannot be used yet. They just have the codes ready to go, so once it's approved, we'll be able to use the codes. The vaccine code is 91308, and the administration codes are 0081A for the first dose and 0082A for the second dose. Like I said, it's for ages 6 months to 4 years. It's a 2-dose administration schedule, and it's 21 days between doses. It does require reconstitution using a diluent, and the counseling is included as part of the administration visit and should not be reported separately. All right, effective February 11th, 2022, CMS released payment for intravenous injections of monoclonal antibodies, and this is not intramuscular like they released previously. This is for the intravenous injection. So that payment rate is $350.50, and it is adjusted based on your geographical location. Also effective February 11th, they updated the payment for the IV injection at home. So this is covering for monoclonal antibodies through IV injection in the patient's home, and that rate is $550.50. Effective February 11th, the FDA issued an EUA for a new monoclonal antibody called bebtelovimab, and it is to be used against the Omicron variant. It's for treatment of mild to moderate COVID and in adults and pediatric patients 12 years in age and older, weighing at least 88 pounds. Patient must have a positive COVID test. It's for patients who are at higher risk for getting severe COVID, or it can be an alternative treatment when the other vaccines are not appropriate for the patient. It's not authorized for patients who are hospitalized or who require oxygen therapy because of COVID, because it may be associated with worse clinical outcomes when it's administered to hospitalized patients with COVID that require high flow oxygen or mechanical ventilation. And we have a new administration code here, MO223, and the reimbursement is $550.50. Effective February 24th, 2022, the FDA revised the EUA for Evusheld to change the dosing to be used as a pre-exposure prophylaxis for the prevention of COVID. Based on the data available, they found that the current dosage that they were using, which was 300 milligrams, was not as active against Omicron subvariants. So they increased the dosage to 600 milligrams to so that this drug could be used against the Omicron variant. So we have a new code for this, the QO221, and you'll see that it has been updated to 600 milligrams here. All right, March 7th, 2022, three new codes for the Moderna booster came out, and this is for patients over 18 years old. CPT codes were 91309 and 0094A. And then the PCS code that would be used for this is XWO23W7. This is for adult patients over 18 years old. It is a new dosing concentration, and it has a booster dose only packaging to use as a safety measure, because the booster at the time was being pulled from primary dose vials. So they did this new packaging as a way to avoid mix-ups when giving this. All right, effective March 29th, 2022, the FDA authorized a second booster for individuals 50 and older. It can either be the Pfizer or the Moderna vaccine. It has to be 4 months since the last booster dose. And for immunocompromised patients, the age does play a part in distinguishing which vaccine is authorized. So for the Pfizer vaccine, a second booster is allowed for patients 12 and older for immunocompromised patients. And then for the Moderna, they have to be over 18 years old. So that's how you can tell which one should be given. And then the coding and reimbursement information is not available for this yet, but I'm sure that we will be presenting it at our next webinar on COVID. So if you want to stay up to date with this, you can check the CMS vaccine and monoclonal antibodies page. It is expected that the reimbursement for the administration of this vaccine will mirror other administration reimbursement, which is $40. All right, getting into our current month. So effective April 1st, we had 2 new PCS codes that were released. And this is for the subcutaneous administration of COVID vaccine. And they are XW013V7 and XW013W7. And I don't know of any current COVID vaccines, like the actual vaccines that are administered subcutaneously. So if you know of any, please let me know. I'd be interested. But from everything I've read, they're all administered intramuscular. So I'm assuming that they're expecting some on the horizon, and that's why they are releasing these codes. So also effective April 1st, CMS released codes for a medication that could potentially be used to treat COVID patients. The medication already exists, and it's called fostamatinib, and it has not been EAU approved for the treatment of COVID yet. But we do have 3 new PCS codes related to this medication, and it's currently approved to treat adult chronic immune thrombocytopenia. I'm not going to pretend to know the mechanism of action here, but it says that it's a spleen tyrosine kinase inhibitor, and it's involved in the intracellular signaling pathways of many different immune cells. So that sounds good to me. So that's how it works. And it is currently being studied to evaluate the effectiveness in COVID patients, and the EUA is under review by the FDA. If this medication is approved for COVID, it will become eligible for the new COVID-19 treatment add-on payment. All right, so effective April 1st, 2022, we also have a new PCS code, XW023Y7, for the introduction of other new technology monoclonal antibody into muscle. So this is going to be used for any new monoclonal antibody that comes up that we don't currently have a code for in PCS. So I think they're just being proactive to make sure there's something that we can use to assign if there's no current code available. Just a note, for the administration of other monoclonal antibodies to treat something other than COVID-19, you would use the PCS table 3E0, not the XW0 code table, sorry. All right, effective April 4th, 2022, CMS released new HCPCS code, a new HCPCS code that we're going to look at on the next slide, and it's related to Medicare covering over-the-counter COVID tests at no cost to patients with Medicare Part B and Medicare Advantage plans. This is going to be effective until the end of the public health emergency. Each patient has up to 8 tests per calendar month, so it's pretty generous. But this only applies to over-the-counter tests. It does not apply to laboratory testing. And then provider and supplier participation is voluntary. The goal of this is really just to find out if Medicare payment for over-the-counter tests will improve access to testing and will ultimately result in Medicare savings on the back end. So providers who participate must be enrolled in Medicare and bill for tests on a standard claim format. Roster bills cannot be used. The HCPCS code is K1034, and that is what you should submit on your claim. No physician's order or supervision is required for this, and those enrolled in Medicare only as a DME supplier do not qualify to participate in this, and it does not apply for inpatient COVID testing. I've supplied a link here. There's lots of additional information here on how to bill and excuse me, anything you could want to know about it is at this link. All right, so effective April 5th, 2022, the FDA announced that sotrovimab is no longer authorized to treat COVID because of the increases in the Omicron variant, and it is unlikely to be effective against this variant, so it's no longer approved. Okay, so this is just some special case scenarios on COVID coding, and this is just to demonstrate some questions that have come up to us at VitalWare and things that many people seem to be confused about that we're just going to try to clear up with these scenarios. So I hope this helps y'all. So first of all, here is a little snippet from the guidelines, and it's just a reminder that you should only code confirmed cases of COVID-19. Typically for inpatient coding, you can pick up if the physician in the discharge summary says possible sepsis, excuse me, that would be okay to pick up since it's a possible diagnosis, but that does not apply to COVID. It must be a confirmed diagnosis to be able to pick up COVID on the record. So we're gonna look at that in more detail on in the next scenario we cover. And then secondly, the COVID code, if it meets the definition of the principal diagnosis, the code is U07.1. It should be sequenced first, and then the following codes should be the associated manifestations. And there is an exception to this if another guideline requires that certain codes be sequenced first. And that can happen with obstetrics, sepsis, or transplant complications. And I do address that in a later slide. So here's our first question. Regarding the newly released COVID-19 guidelines in relation to uncertain diagnosis guideline, which refers to diagnoses documented at the time of discharge stated as possible, probable, etc. Can cases be coded as confirmed COVID-19 if the test results don't come back until a few days after and the patient has already been discharged? Provider documented probable COVID at the time of discharge. So the answer to this is yes. If a test is performed during the visit or hospitalization, but the results come back after discharge positive for COVID-19, then it should be coded as confirmed COVID-19. You do not need the physician to come back and say that, the test came back and the patient is positive for COVID-19. I mean, that would be great, but that's unrealistic in most circumstances. So if the doctor did document that the patient has probable COVID and you have a test that comes back positive, you can go ahead and pick that up. All right, next question. A patient was diagnosed with Guillain-Barré syndrome, which is likely a parainfectious complication of recent COVID-19 infection. The patient no longer has COVID-19. How should this be coded? Assign code G61.0 Guillain-Barré syndrome as the principal diagnosis, followed by code U09.9 post-COVID-19 condition unspecified for discharges or encounters on or after October 1st, 2021. So that's when this post-COVID code was actually released. All right, next question. How is an encounter or admission for COVID-19 associated pneumonia coded when the patient's last COVID-19 test results are negative? All right, in this situation, you would assign code U071 COVID-19 as the principal diagnosis because the pneumonia is an acute manifestation of the COVID-19 infection. Assign code J12.82, pneumonia due to coronavirus disease, as an additional diagnosis. The instructional note under code U07.1 directs to use an additional code to identify pneumonia or other manifestations, and that's what we talked about in the guidelines a few slides ago. Therefore, when a patient presents with an acute manifestation of COVID-19, such as pneumonia, code U07.1 should be reported as the principal, regardless whether the patient's most recent COVID test is positive or negative. All right, next question. What is the correct sequencing for a patient who is status post-lung transplant admitted for management of respiratory manifestations of COVID-19? Assign code T86.812, lung transplant infection, as the principal or first listed diagnosis, followed by code U07.1 COVID-19. This sequence is supported by the tabular list note at code T86.812 to use additional code to specify infection. The official guidelines state that a transplant complication code is only assigned if the complication affects the function of the transplanted organ. In this case, the COVID-19 is affecting the function of the transplanted lung. If you recall in the guidelines, I brought up, it did say that COVID should always be sequenced first, except in certain instances such as obstetrics, sepsis, and transplant, or when the tabular instructs otherwise. Okay, before our next scenario, here's just a few little reminders. So what is a third dose? What is a third vaccine dose? A third dose is when the initial immune response following the first two doses is likely to be insufficient, and the patient requires a third dose to be considered fully vaccinated. And this is usually for patients who are immunocompromised or have some type of clinical indication that causes their immune system to just not react how it should, not react fully to the two-dose schedule. So that's when they need that third dose. A booster is different because for a booster, the initial response to the primary series of vaccines, it did create a sufficient reaction to the vaccine, but it's waned over time. So they need a booster just to get it back up there, get their immune system back up there. So how should we code in a scenario where a patient received a first, second, and third vaccination of Moderna with the booster of Pfizer? And I love this meme. It's just, I think she's so funny. Okay, so even though the booster dose was the patient's first dose of a Pfizer formulation, the appropriate booster dose administration code should be used. So the Pfizer booster dose code should be used. Just remember the sequence of the shot first, then the manufacturer. So you always need to go with what sequence is being given first before you worry about the manufacturer. All right, before we wrap up, I just want to take a minute to introduce VitalWare. If you're new here, I know we have lots of participants on this webinar. So I just wanted to let you know that VitalWare is part of Health Catalyst, and we offer products to help our clients with more efficient revenue cycle processes. And we really take pride in the fact that we keep our systems up to date with the latest content and rules and regulations, literally on a daily basis. So we really go out of our way to assist our clients, and we want the best for their revenue cycle teams. And you can find more information on vitalware.com. All right, and I guess I can do some questions now since we have some time. Let me just pull up the question and answers. All right. Okay, so, all right, sorry guys, I'm coming. All right, so in regard to the free COVID tests for Medicare Part B and Medicare Advantage plans, how can patients with Medicare Part A or private insurance get free over-the-counter tests? Okay, so Medicare Part A, that covers your inpatient stays, your skilled nursing facilities, hospice, some home health. They can get free tests through other government-led programs. One that I know of is covidtest.gov, and it operates through the U.S. Postal Service. So that is something to check out. Private insurance plans, they have their own coverage policies, so they would really need to check with their specific policy to see how you would get that covered. All right, let's see. What situations apply to get the additional in-home payment for administering the COVID-19 vaccine? Okay, so there are additional payments that you can get to administer the COVID vaccine in the home. And in order to get that additional payment, you really need to provide documentation on the record of the barriers that the patient faces to, leave the home and come and get the vaccine. So this could be that the patient has an illness or an injury that prevents them from, coming to the office. It could be that the patient is severely immunocompromised and, the risk of contracting the disease just going somewhere is too high. They just want it has to be a considerable and taxing effort for the patient to leave the home to go get it. And this needs to be documented in the record. All right, let's see. If remdesivir is administered for treatment of a clinical condition other than COVID-19, should one of the new ICD-10 PCS codes in table XWO be assigned? No. So if remdesivir or any of the monoclonal antibodies are given for any other reason besides COVID, you would not use any of the codes in the table XWO for PCS. You would use the PCS table 3EO. So that's how you would assign those codes. All right, let's see. All right, let's see. Should code U09.9 post-COVID condition be used for manifestations of an active COVID condition? Okay, I can see how this can be confusing for sure, but no, this is used only for a condition that the patient developed because of COVID, but the patient does not have active COVID any longer. So, so it would be like the patient had COVID, developed this condition, then the patient got over COVID, but like this condition is just not going away. And they have to continue seeing the doctor for this condition. So that's when that post-COVID condition code would be used. If the patient currently has COVID and has manifestations, then you would want to use the COVID diagnosis code, the U071, as your principal, and then you would, code the appropriate manifestations as secondary codes. All right, let's see. All right. Where can you reference for the determination of what is considered fully vaccinated for each type of vaccine? So if you go to the CMS vaccine page, I have it linked, I think, in my references. It gives the detail of each vaccine and how many have 2 doses, how many have 3 doses. And then you can reference it like that, and you can see if the patient is fully vaccinated. There's actually a nice chart on the CMS website that really goes into detail with that. So that's where you can look for that. And just to inform y'all, everything I answer live here, we're also going to put in the question and answer document on the website so that you can reference the answers. All right, let's see. Is there a separate code for second booster vaccine, or we should use the same codes for booster 1 and booster 2? Yes, there are if there is an EUA allowance for a second booster, there is a second booster code. And I can include those whenever I type up the answers, I can include those. All right, let's see. Would under-immunized status be assigned if a patient received their first COVID vaccine but has not received a booster? Or would it be assigned if the patient received the first dose of Pfizer or Moderna vaccine, but not the second dose of the COVID? So I think that for these scenarios, a more appropriate code would be the partial. Let me find it. It's the Z28 code. Let's see. Okay, so if they had their vaccine but not the booster, or if they only had the one of the doses, I think you would use the partially vaccinated for COVID-19 code, which is the Z28.311, rather than the under-immunized status, because that under-immunized status is, from what I read, it sounds like it's just more of a vague, it's just not concerning just COVID. So if it's just COVID you're talking about, I would stick with that partially vaccinated code. All right, let's see. If patient is under-vaccinated for COVID and all other vaccines, would the general Z code cover all vaccines, or would the Z code for the unvaccinated for COVID also have to be coded? Wow, that's a good question. I'm leaning towards that the Z28.39, the under immunization, would cover everything. But let me check on that, because I'm wondering if you can use that along with the, unvaccinated for COVID-19 or partially vaccinated for COVID-19 codes. So let me check on that and see what I can find in regard to that before I answer definitely. All right, let's see. Lots of question about the under immunization status. Let's see. So under immunization status, can this be assumed from list of immunizations, which may list one dose given, but nothing regarding more, or should be based off of documentation only? So in order to pick this up, I think that the doctor needs to document it. As with everything else, pretty much, this has not been added. I know there are several things that, such as like BMI and things like that, that are allowed to be picked up without physician documentation, but this has not been added as one of them yet. It may in the future. So I would definitely say that the physician should document that before picking that up. Okay, so if they have 2 doses of Pfizer and no booster, is that considered fully vaccinated or partially vaccinated? So she's saying Z28310 unvaccinated for COVID. It definitely wouldn't be that one, because they have unvaccinated for COVID, that Z28.310. That you only want to use that if they have not had any doses of vaccines for COVID. So that one would definitely be eliminated. So that, and then your booster, I'm going to double check on this. It was my understanding that the partially would be used here if there's no booster, but let me check on that, because I'm going back and forth in my head if it's just the main vaccines that count towards partially, or if it's the booster too. They didn't really clarify that in the definition, so I'm going to definitely go back, check on that, and I will update that in the questions for y'all. Okay, so it says it was mentioned in the presentation that a pediatric patient is a patient who is at least 12 years old and weighs approximately 88 pounds. What if the patient meets one criteria and not the other? For example, if there's an 8-year-old who weighs more than 88 pounds, or if there's a 12-year-old who does not weigh at least 88 pounds. So this is something, that's a really good question. I did notice in many of the descriptions, it does say for the vaccines, it says 12 years old and weighs 88 pounds. So to me, that means that the patient has to meet both of those criteria in order to get the vaccine. Now there was one, I can't remember if it was for the antibody or the vaccine, but there was one that it kind of gave a little more leeway, like it said, if the patient was this age but weighed this, then but I think for the most part, most of the vaccines, they have to meet both. They have to be 12 and be 88 pounds at least. All right, let's see. So it says, I'm starting to see inpatients who are being seen for other reasons, but have an incidental finding of COVID. What is the suggestion for coding these? So in the guidelines, it says that if COVID meets the definition for primary diagnosis, principal diagnosis, then it should be sequenced first. So if COVID does not meet doesn't meet the definition of the principal diagnosis, which is after careful study is the reason for admission, that should not be your principal diagnosis. So if it's just an incidental finding, you would definitely want to code it, but it would not be your principal diagnosis. I mean, this is also going off of your physician's documentation. So if it's an incidental finding, but then the doctor says, oh, well, COVID is what's causing all of this other stuff that we're treating, then yes, if he links that and says the COVID is the reason for all of this and for the admission, you would put that as your first principle. But if he just says this has nothing to do with the COVID, why the patient's in the hospital, then you would not put that as your principal diagnosis. What if the test is negative? I'm assuming this question is meaning for that. I'm assuming that they are meaning for that scenario where the doctor documented probable COVID and then the patient was discharged and then the test result comes back negative. Okay, so in this case, the coder would not pick up the COVID-19 as the principal diagnosis or as a diagnosis on the record. The coder would pick up the symptoms that were treated essentially. I would recommend in this case that the coder, the clinical documentation improvement specialist or whoever would contact the physician and say, look, and query them and say, we got this result back. It is negative. When you discharge the patient, you said probable COVID. What are your thoughts now? And it may cause the doctor to kind of go back to the drawing board, but he may need to add additional documentation on what he thinks was going on since it wasn't COVID. So if you can't query the doctor or you can't get any more documentation from the doctor, the coder is just left to, you're going to have to code the symptoms. You're not going to be able to pick up that COVID. Okay, so if a patient self-reports positive at-home COVID test and there's no inpatient COVID test in the report, is U07.1 allowed? So for this, if the physician documents that it was a positive COVID case, then you can pick it up in the coding world. However, I have seen some, and I can't recall off the top of my head, but I have seen some instances for example, for like the 20% payment that the new treatments based on COVID, the new COVID-19 treatments, that 20% payback you can get, like they require a laboratory test saying that the patient had COVID. So doctor's documentation is not the only thing that's required in that case. So from the coding perspective, the documentation is enough if the doctor says patient is positive for COVID. But from some other perspectives may not be good enough. I think the best thing you can do is have both that, you know, that test, that positive test, and the documentation. All right. Let's see. We have 2 minutes left, so let's see. We might be able to get one question in. Does the provider have to document pneumonia due to COVID-19 for us to code J1282? Yes, so I would recommend that the doctor always links any manifestations to the COVID. That is the guideline, that they do need to link that for you to be able to pick that up. There are quite a bit more questions here. I will definitely type these up and the ones I answered already, and I will provide them to Marie to post on the website for everyone. And I really hope that this was helpful and that y'all enjoyed this webinar.
Yeah, thanks so much, Mickey. That was awesome. Lots of great feedback. And just so everybody knows, the CEU certificates will be sent out over email. Just give us until end of day tomorrow because there were so many participants, so it'll take us a while to get that list prepared. So if you don't receive it by end of day tomorrow, you can send us an email and we'll make sure that you get it. And the slides are actually already available on our website, and the recording will be posted as soon as we get that prepared as well, which should be by end of day today. And I think that's all. Thank you so much, everyone, for joining us, and have a great rest of your day. We'll see you next time. Thanks.